Now I think we can move on to the panel discussion. I would like to invite Dr. Anand Kumar, who is a consultant pediatric hematologist and oncologist at Spurs Super Specialty Hospital, Bengaluru, to introduce his panel.
Am I audible?
Yeah.
Yeah. Are my slides visible?
Yes.
Are they in the slide presentation mode? Hello?
No, they are not.
Now?
Right. Yeah.
Yeah. Okay. Thank you very much for the opportunity. So most of the things will be a kind of a revision, whatever Dr. Kateva and Dr. Divya has told. I'll try to add in a new dimension as and when possible. So today we have an expert panelist headed by Dr. Satyendra Kateva, who is the Director of Blood and Bone Marrow Transplant at Shalby Center Hospital, Gurugram, and Dr. Divya Sethia, who is the Consultant Head, Department of Transfusion Medicine at Yashoda Med City, and followed by Dr. Dhwani Thakur, who is a consultant hemonc and BMT at Medanta, Gurugram. So today's topic, this will be the agenda of my discussion. So before I go into the actual topic, I thought I will just introduce what is going on in terms of numbers across the world and in India. So if you see in US, according to the CABMT study, most common indication for allogeneic transplant is leukemias, ALL and AML. Whereas in India, the most common indication for allogeneic transplant has been benign disorders like thalassemia and sickle cell, this thing. In autologous neuroblastomas do come first. Whereas you see as a graft source, bone marrow is the predominant source, 2/3 of it, followed by PBSC and umbilical cord blood. Whereas you see this recent ISBMT study, the presentation wherein, as expected, most of them are the peripheral blood, maximum number are the peripheral blood source, followed by bone marrow transplant, bone marrow as a graft source. So there are specific reasons why we Indians, we try to use more peripheral blood rather than bone marrow. Have we become lazy, or is, like Dr. Kateva mentioned, is bone marrow a forgotten art? So we'll try to find out and search for some answers. So first, let's talk about the graft source before going to the actual topic. So when we talk about the graft source, we need to talk about the donor. So we take into consideration that donor safety before we proceed to either a bone marrow harvest or a peripheral blood stem cell harvest. So in general, we have to rule out the donor is pregnant or not. 7 days prior to the starting donor mobilization regimens, at least a urine pregnancy test has to be done. Breastfeeding has to be altered, as it can be affected by anesthesia or GCSF or plerixafor. Acute medical conditions we should be aware of. Significant organ morbidities has to be taken care of. Simple blood tests like CBC with differential counts and urinalysis at least has to be done. With respect to bone marrow collection, when the patient is undergoing anesthesia or a bone marrow harvest from the hip region and this thing, the things that we have to be aware of, any serious neck, back, spine or hip conditions or surgery that has been done in these regions, or oropharyngeal disease or OSA, which can prevent from easy intubation, and bleeding risks or conditions has to be noted. When there is a high recipient to donor blood volume, higher volumes of bone marrow may have to be collected. So good practice would be to do a pre-op autologous donations, also good. With respect to peripheral blood, we should ensure that the donor has not be that look can significantly lower the platelet count. And we all heard about the of CVC placement in younger donors, the risk of GA and side effects. And renal function test has to be checked, because plerixafor, if you're using, it has predominantly renal clearance, and 1/3 dose has to be reduced if the clearance is lower. If you are using GCSF in a sickle cell disease patient, it can cause life-threatening event, veno-occlusive crisis. So hemoglobin electrophoresis screening has to be done. But sickle cell traits as a safe. Those donors who are existing splenomegaly, GCSF can cause a splenic enlargement and rupture. So there's a risk that is. If you're giving
I
think
guess
Dr. Anand is logged off. If
accidentally logged out. Yeah, so I'm just
I'll call him. So if you guys can
okay.
actually start some discussion on, I know I was wanting to know cryopreservation. I think we had Divya kind of
Yes.
racing that through. So two things on cryopreservation. One was, the pros and cons of dump freeze versus. I think she mentioned the resources, but any other comparison she would like to make. And also a question which is there is that how long you can dump freeze and keep it with a reasonable viability. And third is, she also touched upon the DMSO toxicities, how much we can safely allow when you infuse, and, what is the kind of safe tolerable limit for DMSO. These three questions were there. So in the meantime, I'll ask Anand if he can join back.
So when we are talking of dump freezing versus controlled rate freezing, controlled rate freezing has been known to cause less cell injury as compared to dump freezing conventionally. However, there are a lot of studies which are coming up saying that dump freezing is as as feasible as doing as controlled rate, and it gives the same amount of viability when we give it to the recipient. So that is being published from a lot of places now. As for how long for we can keep it, so we usually tend to keep it for a short duration, but then there are also publications which say that they've done it for long term and they've had successful viability. So you need to validate it at your place, how dump freezing is being done and how is the viability coming out at your particular place. Um,
So,
the
Dr.
next.
Divya, do you want to put the numbers like we want preferably for this many days, but then studies has safely suggested so many months or days can be done. So just for the understanding of all the participants, that how do we look at it in terms of numbers?
Sir, so when we are looking at dump freezing, it is usually done for autologous transplants. And in autologous transplants, you would want to keep it uh, for a month, probably. So for autologous transplants, it is very feasible and you can easily do it. However, if you are planning it for long term, say for more than a year or so, then it needs to be validated at your particular center.
So for all the practical purpose, dump freezing for 1 to 3 months is going to be okay. 1 month absolutely okay types. Up to 3 months, not more than 3 months, right?
Yes, sir.
Other question they asked was that when we was doing the DMSO, so DMO toxicities and the type of DMSO which is used in India, like 5%, 10%, 12.5%, which is the most common in terms of toxicity and rest of the things.
Usually, the protocols that we use keep a concentration of DMSO between 5 and 10%. The more the DMSO, the chances of toxicity are more. And we might want to reduce the number of bags that we are giving in a day and probably plan it over 2 days if the concentration of DMSO is more. So usually 1 gram per kg per day is what is the tolerable limit, and you should not go beyond that. That is the safe limit.
So I just want to, make something. So Anand is back, and before I just, so when we are doing the cryopreservation, there is a bag, donor bag, and then we are adding DMSO. So 10% DMSO doesn't mean if you have added, so let us say the final product is like 100 ml. So then even if you have used 10%, you see the amount of DMSO you have added. So maybe the 10% ultimately becomes like 5% or 6% type, because ultimately the amount of DMSO that has gone to make the final product. So please remember that calculation as well. Yeah, Anand is back, I guess. Anand, can you hear us? We can't hear you. Are you muted? No?
Yeah, now I'm audible.
Yes, you are audible now. You can
Okay.
make it now. Yeah.
Yeah, Dhwani, so can you just tell us what factors you consider while selecting peripheral blood or a bone marrow as a graft in your patients?
Yeah, so as we heard in the previous talk that we can base our choice based on the indication of transplant per se. However, we can choose a bone marrow graft for malignant, non-malignant both, and peripheral blood as such for malignant conditions are usually preferred. But also it depends a lot on the center's choice, their experience, and the feasibility. So those are usually the major factors that we consider when we opt for the graft source.
Right. So generally, as he said, it's preferred. Peripheral blood is preferred in malignant settings because of the risk of faster engraftment and GVT effect, and when there are actually active infections, peripheral blood is preferred. But bone marrow, as it's used, as Dr. Kateva mentioned in his talk. So, Dr. Kateva, what are the HPC targets for PBSC and bone marrow that you follow in your practice?
Yeah. So thanks, Anand, for the question. So let us simplify this. So for autologous transplant, it is between 3 to 5 million per kilo. And please remember, if you give more than 5, it does not help at all. And there are some small case series that more than 5 or 7.5 leads to engraftment syndrome even in autologous transplant. So when you're talking about autologous transplant, keep between 3 to 5 million per kilo. In allogenic, you keep 5 plus minus 1, 4 to 6 million per kilo. And if you give more than 7.5 or 8, there is more GVHD. So please do not give that. Then in allogenic transplant, but haplo, there is a concept of mega dose. And this is a concept which everybody needs to understand. Please do not think if you are using that, mega dose is going to help you. If you're using only CD34 selected transplant, then this mega CD34 dosing, which we call it like veto effect works. But if you are using a negative selection transplant like TCR alpha beta, CD45RA depletion, then giving more stem cells, more than now there is data that more than 8 or 9 leads to GVHD, even in T cell depleted transplant. So this concept of megadose was there for just for CD stem cell. Now in bone marrow harvest, the simple thing is if you are going to use TNC, simple 3 to 5, but now rather than 10 raised to power 6, it is 10 raised to power 8 because they are 2 log more than the routine CD34. Because remember, out of every 100 cells, we are going to have 1 cell which is CD34. So that's how it is. Everything is looking like.
So in PTCY, is there any difference that you see or you follow the same thing?
No, so in PTCI now the data is very clear that you keep your stem cell dose between 5, 6, 7 million per kilo. There is no need to give it more. If you give it more, there is more CRS, there is more GVHT. So most of the centers are now sticking to 5, 6, 7 million, and they are not going beyond that.
Right. So now we know our graft sources. We'll see how we mobilize them. So as Dr. Divya has said, we commonly use GCSF, Tarexafor, or chemotherapy. So GCSF is a standard thing we give for day 4 till day 4, and day 5 we do the harvest. So there are some situations when we use chemomobilization, like in refractory lymphomas. We commonly use cyclophosphamide etoposide. There are no large randomized control studies to say that this is better than that. But general take home message is like with chemo mobilized GCSF, along with GCSF, the CD34 collection is better than GCSF alone. So this is the comparison which shows that with GCSF, the advantage is that the onset of collection is very predictable, and it is a shorter time from the start of mobilization to the transplant. But in chemotherapy mobilized HPC, this advantage is lost. Like you don't know exactly when you are able to do the harvest. There is always added risk of neutropenia, thrombocytopenia, and higher risk of infection, which will lead to more complications and higher cost of hospital stay. If we are lucky, we can get away with GCSF or chemo sometimes. And but as we are sure that most of transplanters are faced with some situations like mobilization failure. So what do you do in those situations? How do you tackle those things, Dr. Kateva?
So first, let us define what is mobilization failure. So let us say we did not have CD34 and there is a center which is doing TNC based apheresis, and they have done once and they have done twice and they have done thrice. So for 3 days they have done with the chemo or just chemo plus GCSF protocol. Usually GCSF is given for 4 to 6 days. After 6 days, the effect goes away. So you have to do the harvesting between 4 to 6 days. So let us say based on TNC, we have attempted thrice. And collective in all three, if the stem cell count is less than 2 million per kilo, we say it's a mobilization failure. But if you have the facility of doing CD34, then you know if post chemotherapy you have given 5 microgram per kilo for 5 to 6 days, and for without chemotherapy you have given 10 microgram for a few days, and still your CDs, if your CD34 in the morning hours is less than 10, it is going to be a problem, and we call it a mobilization failure almost. And these are the situations where you expect it, like a very thin built person, poor nutrition, diabetes, person who has been multiple line of chemotherapy, he has been given a lot of radiation to the pelvic bones, the end of the long bones, the flat bones, and then there is a disease which is massively there, the bone marrow is badly affected, the cellularity has gone down, then there is previous exposure of fludarabine, then there is previous exposure of lenalidomide, melphalan, bendamustine. These are the drugs, where you do not want to, you are expecting that it is going to be a failure. Now, if this is going to be a failure, you expect that, after this much things are not going to work, or you expect that whenever the patient is recovering post chemo, the thrombocytopenia recovery is a problem. These are the very, very difficult to mobilize patient. Then you start thinking about Plerixafor. So now these are the patient where you use Plerixafor. Now, Plerixafor is simple that, you have, whether you have just used GCSF or whether you have just chemotherapy plus GCSF, you decide when to use Plerixafor. Please remember, if you have only used GCSF and it was a mobilization failure, you add Plerixafor, 70% of the patient will be taken care. But if you have used GCSF plus chemotherapy plus GCSF and still it is not mobilizing, then adding Plerixafor is going to help. If your morning CD34 or your evening CD34 the day before you are going to collect the cells, it's still CD34 is less than 10, then you better use Plerixafor. Between 10 to 20, it's going to be okay. More than 20 is going to be very fine. But if you see you have used chemo and then while recovery you are giving GCSF, and still tomorrow is the day when you want to collect the cell, usually on the 5th day of the GCSF you want to collect it, but your CD34 in the late evening or the early morning is still less than 10, my CD34 is less than 10, then still it's going to be failed. So please use Plerixafor. Now, difficult mobilizers, you please remember 4 to 6 or 7 hours is the window. For the normal mobilizers for Plerixafor, 10-hour window is required for the best effect. But for difficult, the drug works different way. So 5 to 6 are sufficient. So that is how we do it.
So as a backup, do you consider, have you done any bone marrow harvest in such cases?
No, I have not done, but all the bigger institutes, they talk to the parent, all the families and the patient, that if nothing works, like first we try with G, then chemotherapy with G, and then Plerixafor, if nothing works, then we have to do the bone marrow harvest. And bone marrow harvest means you take the environment, the stem cells and everything, and that's how it is done. I have never used it because most of the time our patients have not been faced with this much of chemotherapy and all radiation. So our patients are okay, but in adult, this is a situation where they very frequently do that.
So we are used to using Plerixafor in autologous setting or in patients with malignancies and everything. But are there any ethical concerns, safety data about using Plerixafor in healthy allogeneic donors? And how is the graft different when you mobilize with the Plerixafor when compared to GCSF alone?
So I'll take a couple of minutes in this. So I don't think we have data about Plerixafor because we have used Plerixafor in difficult mobilizers, and other than that, they're the difficult healthy donor mobilizing donors. They are healthy at the end of the day. So we have used Plerixafor in few hundreds of those patients, and we have data to say that yes, it is relatively safe. and I'm sure in the next 2-3 years it will be available. But the best, and I don't see any ethical concern, because right now when you are stuck, you have to use it. But upfront is something which needs to be talked with the family. But I'm sure in the next 2-3 years it will be the standard of care. Even the upfront thing will be, because data will be of almost 8-10 years. Now, what is the best part of Plerixafor is it changes your graft completely. Now, understand, if you collect a graft after just by using GCSF from a healthy allogenic donor versus a Plerixafor use, GCSF plus Plerixafor, with Plerixafor, it's a different ball game. So the whole graft is different because there are more number of stem cells. Those stem cells have more number expression of CD45RA plus cells, CD123 cells, NK cells are bright, they have pre-dendritic cells. And what does it mean? So normally with Plerixafor, more number of CD8 cells also come into the bag. So they should cause more GVHD, but that doesn't happen because with Plerixafor in the graft, you have CD45RA regulatory T cells. So those regulatory T cells negate out the effect of increased CD8 cells into the graft, whatever we have collected. Then with Plerixafor, you have more expression of CXCR4, and more expression of CXCR4 take the stem cells into the bone marrow niches. There is a stabler graft and everything is fine. And then Plerixafor also have the NK cells, bright NK cells and pre-dendritic cells, and they both decrease the chronic GVHD. So with the use of Plerixafor, better engraftment, less GVHD, and overall outcome gets better.
Thank you, Dr. Satyeva. So, Dr. Dhwani, can you just tell us the difference between, is there any difference between G-prime bone marrow versus the unprimed bone marrow and when compared to PBSC? So Dr. Satyendra just touched upon it in his talk, but what are the evidence and what is your opinion?
So basically, when we look at the basic differences between the bone marrow graft and the PBSC grafts, we know what the differences are and how we choose and opt for one of them. However, if we look at the G prime marrow, it's like it can be used in case if there's a lot of weight discrepancy between the donor and the recipient, and if we need a higher yield. However, there hasn't been much difference in the engraftment rates and or other outcomes like GVHD, severe GVHD, and also it hasn't been a lot different.
I agree, Dr. Dhwani. So let's come to the peripheral blood stem cell harvest. So there are many challenges in pediatric PBSC harvest, as pointed out by Dr. Divya. Difficult vascular access, managing the extracorporeal volume, calculation of total blood volumes, anticoagulation. So a lot of things have to be managed. So we all know about the importance of extracorporeal volume, as Dr. Divya mentioned. So, Dr. Dhwani, what is the importance of managing the ECV in your pediatric patients, donors in your setting?
Yeah, so when we're looking at pediatric donors, they are small children. So we have to be very careful when we plan this harvest. So when we have a child who's weighing less, like less than 20-25 kgs, the ECV can be more, and so it can be more than the total blood volume which is expected. And so we need to kind of be wary of the fact that we need to prime the tubings, etc., with red cells before starting the harvest so that they are not depleted, they don't get hypovolemia and anemia. So that is something that is very important, and we have to be cautious about that.
Thank you, Dr. Dhwani. So Dr. Divya spoke about various devices and its uses. So I just want to briefly ask Dr. Divya, can you just crisply tell us, like, see, there are small transplant centers, there are large transplant centers. Small transplant centers cannot afford for a spectroptia, say. So is Comtech is okay, or should we really go for spectroptia? Can you just tell us the key differences and its utility? Dr. Divya.
So when we look at these devices, the first thing that we need to understand is that all the three devices that I had shown, that is Comtech, Optia, and Amicus, they are all equivalent when it comes to HPC collection. However, when we look at the product, with respect to purity of the cells, the purity of the cells is slightly better when we use Optia or Amicus. And Amicus is actually an equipment which uses a technique to reduce the platelet loss from the donor into the product. So definitely the product will be more pure with Optia and Amicus, but the yield that you are targeting, the dose that you are targeting, that can be achieved by all three equipment. When you're planning a center in a low resource setting, uh, you need to plan it accordingly. So when you're starting something, Comtech is a device which has very easy troubleshooting. So your staff will actually be very comfortable with Comtech as compared to Amicus and Optia. Uh, so you can plan accordingly. The cost of Comtech is roughly half the price of Optia or Amicus. So again, you can get two equipment, which when you're starting a program, where one can also serve as a backup to the other equipment, because this is a technical equipment and it can have a breakdown, and we cannot afford to have a breakdown on the day of harvest.
Okay, thank you, Dr. Divya. So I think in your talk, you briefly mentioned about how to calculate the total blood volume and these are age-wise total blood volumes. And this is some of the NMDP data that how much apheresis can be done according to the body weight. And you also spoke about the large volume leukapheresis, what are the pros and cons about it. So, Dr. Dhwani, can you just briefly tell us about the peripheral blood apheresis procedure complications? How do you manage those? I think Dr. Divya mentioned it, but just can you just briefly go through it? Thank you.
Yeah. So when we have a patient who's undergoing a peripheral blood harvest, there can be a lot that can go wrong. So right from the venous access, if so we might get complications related to the venous access. It might work, it might not work. So that is something that is important. Then can be machine malfunctions. Then if we look at the donor per se, we have to be careful about the fluid balance. The electrolyte disturbances can happen, like hypocalcemia, hypokalemia. So all these things need to be monitored, and so these are some of the common things which can go wrong, and we have to pay attention to them and monitor the
Okay.
patient.
Yeah.
So I just want to, add
Dr.
one thing. So
Dhwani.
all the time we are
So,
worried about is
regarding the bone marrow
hypocalcemia.
harvest, Dr.
But please remember, with this citrate, lot of alkalosis is there, and hypokalemia can be a problem. And if
Correct.
we are
Yeah.
gonna use, either if your patient is already onto some sort of antifungal agent like amphotericin B and all that, and hypokalemia is there, then it can be a severe problem. So please understand that this is something, this is from the donor, but understand hypokalemia can be there even in donor because of the citrate.
So bone marrow harvest, Dr. Satyendra Kateva has covered it very well. So he has mentioned about the mid-harvest CD34 TNC. So Dr. Kateva, so what exactly do you do? Do you do mid-harvest CD34 or TNC, and how are they different? Can you just briefly tell us about it?
So Anand, there are two ways to do it. If your CD34 and lab is ready all the time, then in the morning, before starting the apheresis, you do the CD34 and you know how to go about it. If your morning lab is not ready, then your blood bank, your transfusion medicine guy has to be smart enough to calculate based on the TNC. And if you are doing bone marrow or the peripheral blood, bone marrow, if you are supposed to harvest 500 ml, once you have collected 250, you send one sample over there. And please always remember, there is always a 10 to 15% increment. Let us say that you have to collect 5 million per kilo, then try to see 5.5 million per kilo you try to collect the stem cell. And if you are using PBSC, then once you have selected a volume around 12 liters and 6 liters is done, then you can send it. And now again, based on the availability of your lab, whether you are doing TNC or CD34, so that's how we do, because CD34 is available, but TNC is also a good idea, and you can safely do that with that part as well.
Thank you, Dr. Katel. So now we have harvested it, and there are some situations where Dr. Divya mentioned that we have to do a product modification. like in ABO incompatibility, there are major, minor, and bidirectional incompatibility based on the blood group of the recipient and the donor, as we see in this slide. Dr. Divya, you mentioned about the modification or processing of the graft in case of major or minor ABO incompatibility. How is it different from peripheral blood and bone marrow? And can you just briefly tell us about it?
So when we talk of major ABO incompatibility, which means that the recipient has some antibodies which are against the antigens that are present on the donor cells. In bone marrow, the red cell contamination inevitably is much higher as compared to a peripheral blood stem cell harvested product. So typically in a harvested product, the red cell contamination will be probably less than 20 ml. And for this, you probably do not need to do anything at all. However, when you're harvesting bone marrow, your contamination will usually be more than 20 to 30 ml. And here you might want to do a manipulation. But what we need to keep in mind is that we also need to check the titer of the implicated antibody in the recipient. So if the titer of the antibody in the recipient is low, you do not have to fear incompatibility or immune hemolysis. However, if the titer is high, then you need to think about manipulation. And usually when we are talking of major incompatible transplants, we keep a cutoff of 16 or 32. And if it is more than that, we might want to do manipulation.
Great, Dr. Divya. Thank you. So, with regard to cryopreservation, as Dr. Divya mentioned, autologous transplant setting we always do, but there are some indications for cryopreservation allogeneic setting, very rarely in match-related donor, in MUD, in post-COVID, where donor availability is limited due to travel or other restrictions, or transplant is delayed because of after the donor has been mobilized for HPC, or it can be used for DLI if any product is left over. Dr. Divya spoke about the cryopreservation solution, what is the cryoprotectant, culture media, and the protein that we use. And she spoke also about the cryoprotectants, about the extracellular and the intracellular cryoprotectants and how they act. So, Dr. Divya, so what do you do in your setup for quality checks, and when do you do the sterility assessment, Dr. Divya? And what is the critical step in cryopreservation in order to improve the cell viability?
So quality check would include sterility, include enumeration, and you need to keep on performing an audit of all the things that you're doing. So when we talk of sterility checks need to be done at the time of collection. It should be done whenever you're doing any sort of processing, and it should be done once you are actually trying to infuse the product.
Hello. Hello.
Hello.
Yeah. So there are some tests to be performed at the time of release of cellular therapy. So there is no particular standardization. We usually do TNC, hematocrit, viability, sterility test, CD34 count, and product quantity. Dr. Kateva, so in a cryopreserved product, how do you test for its efficacy? Like you look for a TNC or a CD34 viability. When and how do you do it?
So again, I'll say, CD34 and flow cytometry are the two best thing, which are the gold standard. So if you have flow cytometry, it relieves the subjective observation bias of the tryptophan blue, the dye test. So CD34 and flow cytometry are the best. But if you do not have the in-hospital, then you can have your protocol for the TNCs. But the gold standard would be CD34 with flow cytometry. And if your pre-cryopreservation viability was more than 90%, then you are likely to have a good cell product even after thawing. Maybe 15 to 30% of the cell loss is expected, depending upon few centers even have less than that. Few centers will have around 20%. So depending upon how old you are and how effective you are in doing the cryopreservation and thawing, most of the time you're going to do well. So if your product is going to be cryopreserved, so normally we calculate the dose and we collect 15% extra. Now here, if your product is going to be cryopreserved, I'll say we collect 30% extra to take care of the thawing and all the cell loss during the process of cryopreservation and the rest of the things.
Okay, thank you.
Yeah,
Dr.
Anand, may I ask a question? Hello, Anand.
Yeah, please.
Hi, Divya. Hello,
Yes, sir.
Divya. So I wanted to check. So what are the essential release criteria? Like I'll give you a hypothetical scenario. So as Anand highlighted, because of various reasons, we might cryopreserve the product now. Before starting the conditioning, would you suggest to do a CD34 enumeration before starting the conditioning to either CD34 count or a viability, or you just do it before infusion, or you just don't do it, go by the pre-transfusion values, sorry, pre-cryopreservation values?
Sir, so ideally we should do it when we are collecting it, when we are actually doing some sort of manipulation, and when we are storing it. So at multiple times of those storage and at the time of release. But all of it, that is just like the ideal scenario, and you might not be able to do it. So
Yeah.
what we would actually recommend is that once you collect it, it should be done, and
True.
uh, once you release it, at that time it should be done.
So release means, you mean at the time of so you
Infusion.
release it just before infusion.
Yes.
Now suppose for any reasons, if the viability is compromised, then will that not be a medical legal issue? So my question is, should we check viability before starting the conditioning as a policy, or just doing it before your infusion is enough? I mean, just hypothetical scenario that you do your
I,
viability
I think
testing
Gaurav, if
just
I may answer, because Divya, of course, is from the transfusion medicine. So yes, you are correct. So you may have your checks in place. You may have your
Mm.
audits and quality controls, which should be ongoing process for anyways for any cryopreservation. Laboratory in your hospital. But we have had instances when
True.
you have infused and you have lost 70% of the cells. So,
Yeah.
and you are infusing suboptimal cell dose, or landing in trouble. So what we have done actually is, and which see, the another problem is that when you may have one or two bags which you have cryopreserved, and you thought the bag for a CD34 enumeration, you're not left with anything. You can't do anything after that. The bag is gone. Either infuse
True.
or
True.
throw it
True.
away, and you can't throw it away because you already conditioned the patient. So what we do is, now with the cryopreservation, we would keep a pilot vial along with the cryopreserved bag in the same cassette, in the same storage conditions. And before you condition the patient, you will take their pilot vial and check it.
Exactly.
That will give
So
a
that's what I
reasonable good
wanted to
idea
convey.
of what is your viability and your count.
Exactly. So
That's
that is
become a
a
part
message I
of
wanted to.
your transplant pathway, and that you do on just before starting conditioning, 1 or 2 days before you
Absolutely.
start conditioning. That what we
So
do, that I think is probably gives us a reassurance that the product is going to be reasonably good when we infuse it.
So thanks,
No, I
Sunil. And
totally agree with you.
another
That was the
important thing.
message which
Yeah.
I wanted to convey to other sort of colleagues, because that's something which we tend to miss. So pre-conditioning viability testing is very important, and I think it should be mandatory thing in the pre-transplant donor recipient workup sheet, that we
And
have
that
checked
gives
the
you the legal
viability.
shield
And
also.
exactly,
But please
exactly.
remember one more thing for all the people who are listening to. If you have thought the product and you have not taken sample, or you have taken sample and you have kept it for 15-20 minutes, and then you are taking it for the assessment and trap, it's going to be false. So please, the moment you have thought it, take the sample to the lab and do all the viability. Otherwise, you are creating a report in the system which is showing false low viability. So the viability testing has to be done stat and immediately, and please remember that do not keep the sample.
So just to add on to that, we in our center also we do this cryopreserved vials, which we send in a dry ice because we don't do flow cytometry in our in-house. So we set it in a dry ice or a temperature logged thing to maintain the temperature throughout the transport, and it is thawed at in the lab bedside, so that we'll get a great result. Okay, so when we take the HPC product out from the deep freezers, it has to be transported on a dry ice that can maintain the temperature of -75 to -80, or we can use this liquid nitrogen shippers to maintain the temperature below 135. So, Dr. Divya, so you briefly mentioned about thawing of the cryo product. So what is the ideal method? Where do you do it, and how do you do it, and what is the role of washing? Do you recommend washing of the DMSO in this products? Thank you.
So, whenever we are performing thawing of the cryo product, it has to be done bedside. This is very important because the viability of a thawed product also goes down very rapidly. So, the moment you have thawed it, you have to infuse the product as soon as possible, and it has to be tested also as soon as possible. As for washing, if you think that the DMSO, the amount of DMSO is more than what you can give to the patient, and you want to do washing, it can be done, but then it comes at a cost also, because there will inevitably be a cell loss, and which has been reported up to some 20 to 30%. Now, if your dose that was actually cryopreserved is adequate enough that even after removing the loss in viability, and if you when you remove the DMSO, that is also accounted for, then you can probably think of removing DMSO. Otherwise, if your total cell dose was just marginal, then talking about DMSO removal is questionable. The other thing is that the handling time should be within 50 to 60 minutes if you're removing DMSO, and this needs to be done as soon as possible. There is a device by the name of Lovo, which is present. I'm not sure if anybody is using it, which is like an automated system where you can remove the DMSO after you have thawed it. But I don't think any of us is using that equipment.
Yeah, great. Thank you, Dr. Divya. So, Dr. Dwani, so when you infuse a thawed product to the patient, what precautions do you do? How do you do it?
So one, we do the thawing at the bedside as we just discussed, and once it is thawed, we immediately give it to the patient by like normal IV sets. We don't use filters so that we don't have a loss of stem cells. And in case if there's any concern regarding blocking of the tubings, we can use a three-way closed system to pull push through the bag, but we don't open the system. So that's the basic way how we infuse the product as soon as possible.
Yeah. So we have to take care of the DMSO quantity when we are considering the infusion of this thawed product, and we keep it to a maximum
of 1
per day.
gram
Yeah.
per kilogram. Yeah.
So if it is more than that, we have to restrict it. I mean, we have to use multiple days of infusion.
Right.
So, Dr. Kateva, what are the complications that you commonly expect with the infusion of the cryo product?
So let us say it like this. There are three main groups. One complication is because of the granulocyte lysis, which is because of the DMSO happening. The other one is the volume of the DMSO product in a small weight patient. And the third one can be because of DMSO. Now, the granulocyte lysis will lead to the lysozyme and the nucleoproteins, and exactly the reactions will be like that of NHFTR, which we call non-hemolytic febrile transfusion reactions. But volume issues, then you know how to deal with this. But with DMSO, the most common are, very simpler things which are like nausea, while giving infusion, vomiting, metallic taste in the mouth. There can be bradyotachycardia, there can be headache, there can be fever, some chills can be there. But if you feel your patient has got severe respiratory distress, chest tightness, some severe cardiac event, some VPCs are there onto the board, then you even have to stop it in between. So it is very, very important that some senior guy has to be around the patient when the thawing product is going in. It can be anything, just simple NHFTR, then simple nausea, vomiting, headache, and all that, and it can be a serious event as well. So we need to be ready with everything around the patient.
So, knowing all these complications, do you routinely pre-medicate with steroid and antihistaminics in your patients?
Antihistaminic for sure, and hydrocortisone is the one which we are using most of the time. And then one thing is also going to happen right after the DMSO. In majority of the patient, you are going to have some dark colored urine once or twice. Don't bother much about that because most of the time it's going to be clear. So we do pre-medication to these patients.
Thank you, Dr. Kateva. So the take-home messages are select the donor properly, choose the graft wisely based on the disease condition, plan your mobilization well, know when to use chemotherapy or plerixafor, understand the technicalities of peripheral blood stem harvest, the man, machine, and the matter. Teamwork for bone marrow harvest is vital, and optimal cryopreservation for good stem cell transplant outcomes is essential. So I'd like to thank my panelists, Dr. Kateva, Dr. Dhwani, and Dr. Divya for their expert opinion. I would like to end my thanks screen share. Thank you.
Thanks, Anand. Thank you.
Thank you.
Thank you very much all, and thank you first of all Dr. Raghuram to chair this session, and all the speakers and panelists. I think it was a very lucid presentation by Satyendra, and very important, Divya. I think you have touched upon the technical aspects of cryo collection and cryopreservation, which are very, very helpful. I'm getting some messages on the group that it's been of immense help to every one of us, because these are some of the less discussed areas in the context of transplant. Also, thanks to Dr. Dhwani for pitching in, and Anand for this interesting question set for the panelists to discuss. So with that, I think there is one question I would want Divya to probably take before we conclude, and that is, if a patient is more than 25 kilos of weight and the hemoglobin is more than 11, you still need to prime or not. So that's one of the things I think we have not discussed already on this panel. You want to take that, Divya?
Sir, so I actually discussed those indications for priming, and if at all none of the criteria fits, I don't think there is a need to perform RBC prime.
Yeah, so I think thumb rule is we all follow is that 25 kilos and more we don't prime. In fact, we have stopped doing priming for more than 20 kilos on Optia, because the extracorporeal volume is lesser than the other machine. So that actually, but 25 is a safe weight actually if your hemoglobin level is normal. No requirement of priming, because at the end of the day, we are giving in unnecessarily packed cell transfusion to the donor in the process of priming. So I think we have to be mindful of that. So so thank you very much again, and I think we will conclude the session now. We're sorry we're a little about time, but it was a very interesting session, I think, and we all were glued to the screens to hear from all of you. Happy New Year to everyone. Merry Christmas, and I think we'll see you after a year. We'll see you back next year with another interesting topic. And stay safe and have a good night. Thank you very much.
Merry Christmas, everyone. Happy New Year. Good night.
Happy New Year. Thank you.
Thank you.
Thank you. Bye-bye.